Happy hour, and it's a pleasure to introduce Dr. Eric Svensson, who's visiting here from Medical University of South Carolina. And Eric obtained his BS degree from Liberty University, got an MS from New York Institute of Technology. He got his PhD in preventive medicine and environmental health at the University of Iowa. And then he did a postdoctoral fellowship at the EPA in Chapel Hill, North Carolina. And he subsequently went to work in South Carolina. He was the state environmental epidemiologist, and he had a faculty appointment at the University of South Carolina. And in 2011, you moved to Tulane, and so he's at Tulane in New Orleans at the School of Public Health there. And then he more recently moved back in 2015 to South Carolina at the Medical University of South Carolina, which is in Charleston. And Eric is really an expert in disaster epidemiology, so he's kind of interested in what happens after these events and health effects on people. And he's really traveled all over the world, lending his expertise to try to understand some of the adverse health effects that these events have had on populations in different areas. And Eric and I have been collaborating on some projects related to chlorine injury. I studied lung disease and lung injury, more in kind of laboratory and animal models, and Eric's expertise is in epidemiology. And
yours behave better than mine.
On population. So kind of trying to bridge the gap between these things to kind of take a more comprehensive look at some of these problems and developing treatments that might be able to then be translated from the laboratory into actual use in people. So I'll turn it over to Eric. I think he'll have a very interesting talk, and I hope you all enjoy it. Thank you.
Well, thank you. So today, is it all right? The light, everyone can see okay? So thank you for coming. It's a joy to be here today and to speak with you about disasters. So the assessing the impacts of public health disasters. So kind of the key is how to have your epi of a disaster, not have your epi being a disaster. So I'll talk a little bit about just what is disaster epi, and then get into some of the methods. And there's kind of two ways of looking at it, and we're going to talk about that. And then how these developed over time. And then if we have time, we'll get into a couple of case studies and kind of show you how this works out in reality. So really the goal within an epidemiologist's role in disasters is not just when something bad happens. If that's all you do, then you're not doing your job. You're really working on trying to prepare for something bad happening. And then when something bad happens, then you also have to be involved in the response, and then how you recover from it. And then also how you learn from what happened. So evidence-based public health, if you're going to have evidence-based public health, you have to have the evidence to support whatever you're going to be doing. So that involves publishing and doing the research and trying to learn from what happened. My focus is on environmental public health disasters, more so than natural disasters, and you'll see some of that, but a lot of the methods kind of cross over between natural disasters and unnatural disasters. And really, I want you to be able to have a better understanding of the roles between the practice side of the house, so to speak, and the research or academic side of the house, and how you balance those out in a case like this. And it really boils down to where do we look at this? What is the anatomy of a disaster? How does it really carve up, and how do we look at different pieces of it and see how we can look at disasters and how we can infuse epidemiology into helping disaster response work better. So this is pretty simple. I just kind of went through this a little bit, just in the prepare, respond, and recover. And I'll talk a little bit more about what you do in each of these types of phases. But this is just a little bit of the jargon that we're talking about. So someone actually got paid to come up with that definition. But it's pretty simple. It's you look at in the dictionary of epidemiology, and that's what you see. So it's pretty simple. It's just using epic in disaster situations, and it's really holistic. It's how do you use epidemiology within practice, which is how, in practice is really giving to the population. Research is taking away. So in these types of scenarios and disasters, we have to remember that, you know, from a public health perspective, this is our patient. You know, we are not just doing the research. We are trying to help treat our patient, which is a population that just went through disaster. And so that's really the practice side of the house. And what do we give to this population? And then what can we learn from this event that we can research and then help us do better public health in the next disaster? And that's the taking away. So there has to be a balance, and we'll talk a little bit about that today. So disaster epidemiology, our patient is a population. It's some folks are clinicians, and so you think in terms of people and treating people, and I'm just trying to frame the context of our discussion today and think about it this way. It's not just what can we learn from a population, how do we help treat them and help them get better. So that's more of a public health perspective to using our EPI tools to help patients. So the other concept that I wanted to really push on is, you know, what should we be doing in disasters, not just what can we do. Oftentimes you get trained in a certain way and you just think about that way of training and you know how to do X, and so I know how to do that, so I'll do that in this kind of scenario and think it's going to be helpful. It might be, it might not be. It might just be that you think it is helpful, but it's not. And that plays out in disasters all the time. People are well-meaning, but it might not be exactly what the population needs at that moment in time. So we have to think about what really should be done, not just what can we do. And every time I read this, I still cringe when I get at this, because the language that's used. From an environmental health perspective, we can learn a lot from these unfortunate events. That's absolutely true. And we have to see if we can learn something. Yes, but we can't just take people, expose them to bad things experimentally. And because of that, we have a lot of gaps in our understanding of exposures in human health. And we rely on our colleagues in animal tox to develop that science. But we also have to remember they're our patient. And we have to remember that they need help too. And so we can't jeopardize the assistance to this population and sacrifice that for the science. And so that's just one thing we have to keep in mind. And my colleagues there know that, just that they talk about that more than the other part of the paper, but that's just something I just want to point out. So what should epidemiologists do? Not what can we do, okay? So something bad happens, and we're trying to mitigate it as best we can, right? We can't turn back the clock and undo something that just happened. But we can try to help minimize the impact of what just happened. So we're trying to prevent epidemics of secondary disease or injury. For those of you who are familiar with natural disasters, a secondary injury from natural disasters, let's say the power goes out for a long period of time, people run generators and they end up poisoning themselves with carbon monoxide because they just run a generator in their house. Well, that's a secondary problem that could be mitigated if you do a good job of trying to prevent that epidemic. That's just a simple example. So also you're trying to look at diseases and injuries that are related, probably didn't frame that the best way, but that are already, or I should say, chronic diseases. I guess that's more the longer term third bullet there. So if you have people who are sick already and then everything goes haywire and something bad just happened, chances are they're going to have problems managing their chronic illness. And so you're trying to address those issues too. Does someone's diabetic coma, is that really caused by the hurricane? Well, no, not directly, but because they weren't able to get their medications and they weren't able to manage their diabetes, then that was the problem that you could have helped solve if you had addressed that beforehand. And then, of course, everything you're doing to help address these issues in advance, you're trying to evaluate them so that you can learn from them moving forward. So How many of you are epi background types of people who have had some kind of training in epidemiology? Okay, so good. Lots of people have had some kind of training. So has anyone ever heard of a cohort study before? Okay. How about a case control study? Okay, we're speaking the same language, right? So these are research methods that people are familiar with. Some of you may have even heard of an ecologic study. One that's less familiar are quasi-experimental study designs. Anyone heard of quasi-experimental? Okay, a few of you, very good. And of course you've heard of randomized controlled trials, but we're not going to randomize populations to disasters and then say, oh, sorry, Cleveland, your turn. But, oh well. So we're not going to talk about that. But in practice, it's a little bit different. So disease surveillance, you've probably heard of that. We're going to do a lot of that. Outbreak investigations, cluster investigations, exposure registries, you've probably heard of these kinds of things too. And looking at interventions and evaluation studies. So these are a little bit different. You may have been familiar somewhat with these, but typically we're trained on the harder quantitative side of things within the research methods and less so in the practice. But when something bad hits, these are the first things you need to really point to are these kinds of assessments. So let's talk about why doing research in a disaster can be really, really scientifically fruitful. Going back to that comment that I showed you a little bit earlier, okay? So essentially you can look at it as a natural experiment, okay? You didn't randomize and get Cleveland, but you had an event, what we would call statistically an act of God, that happened, a random event. And so you could say that this is a random event that happened and some people got exposed to X, Y, or Z, and some people didn't. And you can say, wow, we can learn a lot from this because you have a randomized exposure. And so that takes a lot of the variability out. So, and then you have this holistic exposure. You have discrete populations, so everyone's right there. So it's easy to study them. You don't have them scattered all over, and you have a multi-center clinical trial kind of craziness where you have people everywhere. You have this unity. Everyone went through this event, and so there's some unity, and they all want to participate in some study because they feel that there's a common bond with them now. And then you have this nice scale of exposure because some folks got exposed to a little bit and then a lot, and you can't really do those kinds of studies ethically in human clinical studies. So that sounds great. Let's do the research in disasters, right? Everything's good. Well, there's also some limitations. So, well, do we have comprehensive clinical data on everyone in a population before something bad happens? Well, usually not. We don't have very good baseline data. So you don't know if what you're measuring really had anything to do with what you just saw that just happened. It could have been something that was going on before the event, or before the exposure. And speaking of exposure, you don't even know exactly what they're exposed to. When you all do your rat studies, you know what they got dosed with. You know, we don't really know when something bad happens. World Trade Center, whatever, you have people, this cloud of dust. You don't have these people with these nice monitors running around measuring what they're exposed to in a disaster. So you have to estimate. So there's a lot of uncertainty there. Discrete sample size can be good because you got everyone right there, but then you could be underpowered because you don't have enough people to really answer the sophisticated questions that you want to look at. So that's a problem. And of course, you have to do the study right away. So how many of you are just sitting around waiting for something bad to happen next door in Indiana, of course? Not here. And then, or you're ready to go and you're just waiting for it to happen. No one's, well, you are, that's right. But everyone else is, yeah, and you're busy too, but everyone's busy doing other stuff. And so you just can't drop everything and then do a study because it's really fruitful. So, and then you have this issue with distrust, like, wait a minute, your government, all these people that should have kept this from happening in the first place. And now you're putting this money to this university to do this study, and why should I trust all the science? Because it's coming from you all, and you should have stopped this from happening. So there's those kinds of issues, and you never have enough people, you never have enough money. You have selection biases. Some people want to participate, some people don't. So depends on their lawyer. And that's a joke, but it's also very true. And trauma, it's not fun going through a disaster. Who wants to sign up for a disaster? Nobody. So you have this, what we call an complete confounding, because they're both exposed to a traumatic event and then a toxic event. And if you look at a health outcome, well, was it caused by the trauma or was it caused by the toxic exposure? Well, depends who you talk to. And so that's a problem. So you go through all this and you say, heck no, there's no way I'm going to do any disaster studies, right? So it's a challenge. But there's still rewards. And you have to keep in mind the needs and the victims and the services. And keep your focus where it needs to be. As an epidemiologist, we have to remember that the first priority is really what can we give to this population that just went through it. And we also have to learn, because we don't want to make the same mistakes the next time. So how do we balance all that out? So one of the biggest concerns that we've had over the years is what I call, folks in our group would call the secondary surge. And most of the time, homeostasis in a medical system is not good. So my guess is here in Louisville, you don't have a population of people where everyone is really robust and healthy. You probably have some folks who are really struggling, and you have some folks who are doing really well. You have a race coming up next week, so you probably have some good runners and healthy people, but you probably have some people with some really serious problems. And so sometimes you have disparities in those rates of health problems across populations, where you have a subpopulation that has more problems than others. And so those can be really a problem in disaster situations, because then you have an overly needy subgroup of your population. And so I'm not going to go through this in great detail. We published this in a separate paper, but this is basically kind of going at the secondary surge, and I'll just try to show you what I mean by that. So I've had a nice talk with one nurse here. Anyone else, a nurse or clinical person in their background here? Other folks, okay. So if you've worked in a hospital, they have what's called a surge plan. So if the bus turns over on the highway and you had all these patients that come through, or there's a stampede at the rock concert or whatever, they have a plan for all of a sudden all these people come in with serious injuries, right? They don't have a plan with, okay, what are we going to do in our medical healthcare system if all of a sudden we have a few hundred chronic illnesses that we have to manage that just show up overnight. And that's a problem, because the people who go through that initial surge, you're ready, you get them in the hospital, you spread them around all these other partner hospitals so everyone gets the care that they need. Well, in an environmental health disaster, they're going to need longer term health care. So are all the other primary care docs who are going to manage these folks just sitting around waiting for another 400 patients to show up? Well, they're not waiting. There's no plan for that. And so that's what we call the secondary surge. And so that's what we're seeing here, is this surge. So this is kind of the baseline, and then you have, in the case of healthcare disparities, the secondary surge gets just even becomes even more of an issue moving forward. So kind of the big premise that we have going into this is, if you do really good public health to start with in a disaster situation, good disaster at the focused on good public health, and that'll help you really be able to do some good science down the road. And then, of course, you do good science, it'll help drive your decisions moving forward, so you can help improve and do good public health moving forward. So this is a little shift into where we're going with, where did this all come from? So some of us in the room may remember this, but there was a big boom out in Washington State in the early 80s from this anyone know when I'm talking about this volcano, Mount St. something? St. Helens. So it had this massive plume of volcanic ash that went all over the place. And as a result of that, there was a very well done, sophisticated effort to assess the health effects of exposure to these dusts, and also efforts to develop the methods to help support communities from disasters. And the chair of my dissertation committee that actually helped write, who's the main paper the main author for this paper that was published in 1986 that kind of summarized all that happened there. There were several different papers within this thematic journal, and one of those really went into some of the details of who does what and when and where, and came up with really nice plans moving forward. And I just wanted, I'm not going to go into all that, that's too much detail for this kind of talk, but one of the things I wanted to really point out was this effort at the very beginning is looking at a community-based, engaged kind of process. It's not top-down, here, we're going to help you with X, Y, or Z. Well, just because you have people who know how to do disasters, they don't know how to do your disaster. They don't know what your specific needs are. And so you have to come from the ground up and work on a community-based approach where you're doing the surveillance that really needs to be done. So, nice set of protocols, nice set of plans, do this, whatever. Well, did anything bad happen since Mount St. Helens? Yeah, a few things. So, Northridge earthquake, that was in LA, the San Francisco one, in the middle of the World Series, I don't know if you remember that one. And back in my now home state of South Carolina, Hurricane Hugo came wiping through and caused a lot of damage. And then this one, it really changed things a lot. It's boom, 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 well, it's not working so well. We had tried this out, well, it didn't work so well. Oh, it didn't work so well. We had all these nice plans, and it didn't work as well as we had hoped. And so some new methods came out after Hurricane Andrew, and I'll get to that in a minute. And then the flood of '93, Fran and Floyd, that smacked North Carolina silly back in the 90s. And then the Oklahoma City bombing. And then after 9/11, everything just went kind of haywire. And so I'll get into that. And then Katrina just was a beautiful mess. So, so this is where I'm just going to say, just take time out. If you're going to have plans, you have to have the science to really show that it's working. So you want to have scientific-based, evidence-based public health, evidence-based medicine. So how are you going to be able to manage that? And so after the Hurricane Andrew, they introduced these, what we call rapid needs assessments. And I think that's just such an incredible misnomer, but it's an attempt. It's not as rapid as you really want, and it doesn't really get all the needs that you need. But it's a really simple way of thinking about things. So top down again, you can't just say, oh, everyone's going to need X, or everyone's going to need Y. We learned the hard way in disasters overseas that if you make assumptions, you're going to end up wasting resources, and you end up sending all the bottles of water to one area, and they don't really need it. They need them over there instead. And you send all the diabetic drugs to this shelter when actually they should have gone over there because that's closer to the population that needed it, and so on and so on and so forth. And so you have to be able to manage that information and provide the services in a way that's rapid and right. And so not everyone in this room is going to need everything. Not everyone in this room is going to need the same types of things. And so if you have an evacuation shelter, you want to find out what everyone needs, but it's not rapid to go and say, okay, can you fill this out and tell me everything you need? And you fill this out and you do this every single person. You don't need to get every single person's needs. When you need the answer, and by the way, I joke, in disasters, the guys with guns run the show, so the public health people want to help people, but we're just helping the public safety folks in these disasters, which makes sense because they can actually move people, unlike us. So we have these rapid needs assessments, which use a cluster-based approach, where you just randomly select a group of people, or in a big room, it could be random quadrants or whatever. You randomly select one of those quadrants, and you randomly select a certain number of people within that quadrant, and then you interview those people. And you can very rapidly get an answer, because the people on the phone are going to say, how many of this and how many of that do you need over in that area? And they're not going to, and if you answer, oh, let me do a survey and find out how many we need. I'll call you back in 2 hours. That's not the answer they want. They want the answer now. And so these types of methods were able to give you really good data really fast. So, and they're not very complex. All right, so where does this all come from? So after all those bad hurricanes and all that mess and everything really didn't work very well, we came up with this law called the Stafford Act, and it's called that because politicians like to name things after themselves. But it's really the Disaster Relief and Emergency Assistance Act. And this is, if you've heard of folks saying there's been a federally declared disaster, have you ever heard that kind of language before? So that's where this comes from. Okay, this law came in 2000 after all that bad stuff happened. They said, we have to do a better job. And so this is a way to help connect the local with the federal resources in a systematic way. And so this came together, and guess what? A year later, we had a really big test of this, and that was with 9/11. And then after 9/11, we said, well, that didn't quite work as well as we had hoped. So now we have to come up with all this other stuff. So all this other stuff is this other stuff. So we came up with these national response plans. We came up with the preparedness goals, the NIMS. Anyone heard of NIMS, National Incident Management System, and ICS, the Incident Command System. We came up with all this effort to really communicate better between the federal and the local. And all this came out after 9/11 and helped to integrate these really well. So great, everything went really well after that, right? So, well, not really. So we still have people addressing the needs, doing the work, and this helped us do that, but we're still not learning our lessons that we needed to. And it's such a problem that in 2013, the heads of NIH, the head of CDC, and other colleagues came together and said, but this is a big problem. We have to be able to integrate research into disasters and disaster response so that we can actually learn something and not keep making the same mistakes over and over and over again. And so this was a New England Journal paper that came out a few years ago. And this was basically the call to action, call to arms, like we have to change what we're doing. And so what happened after this? Well, a few things I'll get to in a minute, but I just want to put a caveat in here that if we're going to collect data, we're going to do research, we have to keep in mind it's intended to be used to do something. And this is an old story. This is not a new quote from Bill Fahey. This is very old, but it goes back to the point of if you're going to collect and analyze data, it should not be done unless you plan to have action to follow. Okay, so let's do the research, but in a way that's planned for action. Okay, so methods. How do we do all this now, moving forward? What are the actions that we're going to do? In the first phase, the pre-impact phase, this is the time to think. Okay, we're not acting right now, but we're thinking because we're going to be acting in the future. So this is the time to develop the protocols, simulate these things, go through these vulnerabilities, train the people, and conduct drills. So, and I understand that some of you have been involved in some of these types of planning activities in the past. Yes? No? Yes. So it's a lot easier to do this kind of work when there's nothing bad staring at you in the face. So, but then something bad happens, and then this is the time to act. This is not the time to think. And that's part of what the problem was. Previously, it was something bad happened, and then the first response was, what should we do? That was the question I gave you earlier. I said we shouldn't be asking, what can we do? It's what should we do? But that question shouldn't be asked in the middle of a disaster. It should be asked before a disaster, so you're ready for something. When the disaster happens, you should be able to pull out a plan and say, we have a plan, and we are going to do this because we're ready. And so this is what happens. During a disaster, you're going to be doing the damage assessments. You're going to have all these protocols ready to go and ready to collect the information you need and do the surveillance, and that be because you have it worked into everything you plan for. Afterwards, this is the time to keep acting and keep thinking really fast because your needs may have changed since the initial response. And so you may have some new needs, some new research, some new help that needs to be done for your patient. And this is an example from a paper that we did from the Chernobyl population showing some dose response effects with exposure to radiation in their diet. So anyway, the point of this whole thing is you have to keep going until you don't need to act anymore. You keep learning, keep treating your patient until your patient is well enough to be considered recovered. All right, that's kind of same thing here. Keep planning, keep doing these interventions, keep conducting these studies until you're finished. All right, so I wanted to point this out. Their websites changed. Websites change over time, but I love this one still, even though it's an old version of it, because it points out the motivation for this whole thing. So this is the World Trade Center Health Registry website from a few years ago. It's a lot more boring now, but anyway, it's there. And part of it that really strikes me and I really like is what's up there at the top. What is the motivation for having this registry? It's this. We need to know about the long-term health effects of 9/11. And this is who? You can't really read it very well in the back, I'm sure, but it says residents of the South Canal neighborhood. All right? So this wasn't the researchers at NYU or Mount Sinai or wherever else saying, you know, we had this really bad thing happen. Why don't we do some studies in the people there? No, it was the other way around. It was something really bad happened here. We don't know what's going to happen to us. Help us find out what's going to happen to us. And that's a big difference in how you do the research and how you do the development of recruitment and everything. It's a profound difference. And so this has been a very fruitful set of studies out of this program. And a lot of it is because it's been focused on what are the needs of the population, how can I help my population, help them recover, and at the same time, what can we learn from it? And this is a fabulous case study of how you manage that very well. And they've done that in New York. Going back to this, what should we do on the science side? So, again, I want you to make sure you understand this. If you want to do good science, you first have to do good public health, and then you get the good science that comes out of it, just like what we just saw in the World Trade Center. And then the other goes around. We've learned a lot, so much from the World Trade Center that it's going to help us in the next big disaster. So, what are some other research issues that we have to think about? So, the ethics of the whole thing. This is where it gets really sensitive because, yes, they may need or want to get involved in a study, but when? Are you going to do that when they're still suffering in a hospital? And no. Or are you going to do it right after they bury their son? Do you want to get enrolled in this study? Well, that's probably not the best time to be talking to them about this. So we have to be sensitive to those types of issues as far as ethics. The issue of beneficence. Is it really going to be helping people that just lost everything to get involved in this study? Well, what are you doing to help them? Well, nothing. We're just going to study them. Well, they're still stuck in that situation where they don't have a house, they don't have food, they don't have all this, that, whatever, but you want to study them. How is that going to help them? Well, some folks don't think that through all the way. It's not that they're intending to do anything harmful, but they just haven't thought it through all that way because they're so focused on their independent research question. That's where you have to really engage the community and say, what can we do to learn, but also help you do some science that's really addresses the issue of beneficence and justice as well. So these are issues that gets really dicey when you start working with disaster populations. You have to be really sensitive to it. So limitations, again, reference group is another one that people are always concerned about. You know, how do you compare it? Because going back to that first method slide I showed you, everyone's accustomed to looking at exposed, unexposed, you know, sick, not sick, those kinds of contrasts. Here we have disaster. Where's the no disaster? Well, it's really difficult to blend the two together because they're night and day different. And you may just be introducing so many other different confounders by bringing in a non-disaster community into your study that it ends up washing everything away. So that's a problem. So another thing to really make sure you remember is a poorly done study makes things worse, wastes resources, and doesn't help anybody. Of course, we talked about the benefits as well. So all this has developed very well since 9/11. We've learned a lot since Katrina, since Rita. And now we have, since that paper in 2013, the NIH has developed what's called the DR2 network, or Disaster Research, and I forget what the second R is for, but they call it the DR2 network. And this is their website, and it's at NIH, and they have all these tools, and they've looked at a lot of these issues very, very closely. And they've done a lot of thinking so that people are ready to act. And they've done a lot of thinking so that people don't have to do all the thinking when something bad happens. And so, for example, they have protocols, IRB protocols, that are written up for very simple types of epi studies that could be done. And you just basically fill in your exposure, fill in your outcome, and then finesse the language a little bit. You don't have to start from scratch. They have other types of protocols in place, like questionnaires that you can use that are already standardized, already beta tested, that you can use for a lot of the simple types of things you want to do for disaster surveillance in study populations. You name it. They've all these nice tools that are available for you if you wanted to get involved in the research side of things. The CDC has developed the same types of tools for the practice side. Those cluster-based tools that I mentioned that were introduced after Hurricane Andrew, they have a whole suite of tools that are now embedded into software systems where you have these specialized questionnaires for doing these rapid needs assessments, and then also doing the analysis of the data so you can find out if you have trends, if you're seeing that you're having more and more people get sick. You can catch an outbreak very quickly within an evacuation shelter, or you can provide the needs to communities in different places very quickly. If people are in their homes and you want to go out and find out what's going on in these people's homes, they have developed this, what's called a Casper system, where you go out and do this cluster-based assessment in the community, where you randomize your community spatially into different quadrants, the same kind of thinking, and you pick those random quadrants. Within those, you pick the random houses. Within those, you pick the random people. And you don't have to talk to everybody. And those tools have been used in Bhopal. They've been used other places overseas. And the Bhopal example, this was genius in my mind. But they developed this tool, cluster system that they were using. They get to someone's house, and they say, I only need to interview, they say, how many people are in your house? And they said, we've got 7. And then they look at their randomized number tables, and they say, I need to talk to the third person after we just number them all out. I only need to talk to you. I say, well, what about me? Don't I count? I'm a victim too. And that's true. And so but you don't need to talk to everybody, right, to get your answer. And their answer was, do you test every grain of rice when you cook your rice, or do you just take a sample and try to see if it's done yet? And they say, oh, we just take a sample. That's what we're trying to do. We're just trying to get the picture. And everyone got it. And I thought that was genius. Anyway. So we can do quasi-experimental studies where we have these types of more sophisticated designs looking at temporal changes. And what's nice about these types of studies, quantitative studies, they're very similar to randomized controlled trials because analytically speaking, as far as how robust they are, and we'll get into some of those issues. You don't have issues like validity and some of these other types of problems that you would have with the more classical type of epi studies designs. And I hit on some of this already. This I'm going to just point to. This is a nice review paper of some of the methods. And I'm not going to go into all the methods because we don't have time. But there are some really nice methods that you can use for quasi-experimental studies in public health practice, not just in disasters, but in a lot of other situations. And the natural experiment is the strongest, and I'm just going to focus a little bit on some of that in a minute here. I will show you some examples. Other examples that you might have seen in some papers, and I'll show you other examples also, are what we call interrupted time series, where you look at the trend in something before something happened, and you look at the trend after, and you look at the slope and all that kind of thing. Regression discontinuity is where it's very similar to that, where you're actually going to do a linear regression and look at that. And then there's just simple pre-post is another tool. But you're looking at stochastic changes in your population over time. So this is a method that's really starting to get some steam behind it within epidemiology and being used in not just disasters, but in other types of applications. And this is a nice paper that did a really good review of showing where it could be used more. And so if you're really interested, you can go and look at this paper. I had nothing to do with that paper, it was just a good paper. So how does this play out in some of the cases that we've been involved with in the past? So 1986, Chernobyl. Do I have to explain Chernobyl to anybody, or does everyone understand Chernobyl? It was a really bad situation, still a bad situation, and you had all this radiation. And this is a large geographic area, by the way. Several countries have been impacted by this. And I'm just going to focus in on some of the studies that we've been doing within the populations right adjacent to the exclusion zone. This is the area where you're not really supposed to go. You can see it mapped out here, kind of zoomed in here. But there's a population right adjacent to it. And it's a peasant population, and which means that they basically eat what they grow. And which means that it's typically contaminated with radiation. So we wanted to do assessment of what they're exposed to. So you can do the plume modeling, you can do the soil testing. This is one thing that's nice about radiation, is that it sticks around. And so you can actually measure it. And that's a bad thing, because it's still a risk, but it's a good thing in that you can actually measure it. We couldn't really do much with measuring the exposures from the World Trade Center and a lot of other types of disasters. And then there's issues with the old political background with the whole thing. And some of this also played into the health side of things, where they had all these incredible health data that were collected early on, but a lot of it just kind of sat in these filing cabinets and paper records for a very, very long period of time. From the West, a lot of folks were thinking, let's do some studies of cancer, because we know that radiation causes cancer. And so a lot of the Western-based studies have really focused on cancer. And this was a fairly well-done series of cross-sectional studies from some Japanese colleagues who went over there and assessed different populations and did basically a really good job of assessing what the epidemiology was in different regions. What we did was we were able to develop a collaboration with some colleagues in Ukraine, where they had been following the same kids and helping them. Their focus was the first part of that dynamic: do good public health. These kids need to be assessed. They are exposed to radiation in their diet, and we want to see if they have any problems. And if they do have any problems, we want to help them. And that's what they had set up. So they were actually providing free medical care for these kids, not just assessing them, but they were going through a very quantitative, rigorous medical evaluation every year, their entire childhood. And they put these data in paper records and stuck them in a filing cabinet. Well, I'm an epidemiologist. You tell me that there's 18 years of data on this child, I'd start salivating. And they said, we want to learn about these data, but we don't know how, because we're clinicians. And so, long story short, we were able to develop a collaboration with this team where we were able to get these digitized, at least 6 years of the data. This isn't the whole set. This is only a series of data. And actually, this paper is from a few years later, not the initial data set. And start looking at them. And they also had whole body burden measurements for their actual radiation dose that they had in their body at that moment. So we were able to look at that and look at kind of health effects. And this is some of the numbers that we looked at there. And so this is an example of where we were able to partner with some folks who are really doing good public health. And then because of that, they were collecting some fantastic data. We were able to do some really good science. And hopefully this will be able to help folks in planning for future events. And I've been involved in Fukushima, so I guess it's already doing that too. But taking another step. So sometimes you do bad public health, or you run out of resources. So I wouldn't say bad public health, but you can't keep doing the same things over and over and over again forever. And so in this situation, early on, they provided 3 meals a day to the kids. And then they ran out of money and provided 2 meals a day to the kids, all at the school, not at home. They provided it at school. So come early, you'll get breakfast, you'll get lunch, and then before you go home, you'll get dinner. And that way, they could help make sure that the kids were not eating the contaminated food while they ran out of money. And then we were seeing funny trends in the data, and we were talking to our colleagues and said, did something happen in 1995 that would have changed the results? And they just kind of looked at each other, well, that's when they stopped giving them 3 meals a day and went to 2 meals a day. And we said, well, maybe that explains what's happening, because now they're getting their main meal, their dinner, at home. And so that's what we did. And this is a regression discontinuity study where we actually looked at the regression. The slopes are different, but there's also a shift, a downshift, and then so everyone's getting a little bit healthier, a little bit better, because the decay of the radiation, and then also beyond just the decay, you're also having some of the erosion of the soil going away, and so you're having less and less exposure in the environment over time. And so you're having better and better and better measures of subclinical health problems. And so we're seeing that, but there's a massive shift there in that time, and that's when they stopped getting an extra meal. So we published that. And I only have a couple minutes left, but I'll just kind of give you the big picture. So chlorine, we have some folks doing chlorine work here, Dr. Boyle's group. It's 2.5 times heavier than air, and so when we had this disaster happen in South Carolina, the chlorine just kind of sat in the valley here in town, and there was no wind, and so it just kind of filled up this bowl. And it was the middle of the night, everyone was mostly at home, or there was a mill right here, they were at work, and just kind of filled up and gassed people while they were asleep or at work. So 53,000 kilograms is a lot. So as a result of that, we had 9 people die right away, 15 in the ICU, and you see the big numbers there, but the big picture was there were 1,300 people that we knew of that got impacted by this. So this landed in my lap. You know, you're the state environmental entity, fix it. So, well, can't fix it, but we could do some of the stuff that I just talked to you about. So one of the things was, how do we estimate exposure? That's one of the problems I just talked to you about. Well, we have tools to be able to model things that can estimate exposure to gases over space and time. And so this is an example. It's not showing up so well, but that's a 3-dimensional model from the Department of Defense model that we were able to get access to show what's going on there. And you can see how it just kind of pushed through the valley there. And you had this initial burst when it exploded, and you have this main release of the chlorine, and then you have this drip after it was open and just sitting there for a while. And we can estimate what people were exposed to because we knew where everyone was. They're at home or they're at work. The folks who we couldn't really estimate well were the emergency responders who were running around everywhere. But we could use that to estimate exposure. We could develop the registries because everyone's there. We could do the screenings of the folks who were there and develop a study long-term, kind of like what we just saw in Chernobyl. So that's kind of what we did. Going back to the Stafford Act, that Disaster Act, there's a clause within the Disaster Act which is this: if there's a substance of concern that's been released, all these different things can happen. And so that's what we said. Our governor, God bless him, he's kind of has some problems in the hiking type of attention that he had, but he got it right and asked for a disaster declaration, but they rejected it. So we had hoped that this would go through and we would be able to do all this with the federal government, but it didn't happen. And so we basically did all these things, on our own in the state. So it's all very simple stuff. Perform baseline and follow up clinical health. All the kind of stuff that we're talking about. You do good public health and you can do the good science. It's spelled out very well here. Study the human health impacts of any exposures. That's what we wanted to do. Provide assistance to individuals, so on and so forth. So health coverage, all that kind of stuff. All the stuff that this was written into the law that was applied to a major disaster already that we saw in the World Trade Center. And that's when it works well. This is why it's there. So, we wanted to do it on our own and do the best we can. So some of the things we wanted to do is tell a story. So here is, you see differences in those lines there, or are they all the same? I hope you say different. So, any ophthalmologists in the room? So these are our two comparison populations. In this case, we had the same county, the same medical system that provided medical care for this community, but they were not in the plume. They were in the zip codes adjacent to the plume zip codes. And then we had the secondary population, which was the next county over. Okay? So and we looked at these, what we call ambulatory care sensitive conditions. Those are the secondary surge conditions, the diabetes, the hypertension, and those other types of health problems. So if this event overwhelmed the healthcare system and it also impacted these people, then we would expect to see changes in the population that was impacted by the disaster. And that's what we see. We see that their numbers were actually improving before this. This happened at the very beginning of 2005, and then the numbers went not the opposite direction after that. So that's the kind of approach in these surveillance data that we use. We look at this also within this is an ARIMA model, autoregressive iterative moving average, if you know what that means. So this is an interrupted time series, and the interruption is right here when this happened. And we wanted to look at it a little bit more specifically. Did our public health work that we did, the interventions, help? So what we were trying to do is get people connected to medical care. So in this case, we would want to see people going to these federally qualified health centers after we did some public health intervention. Well, we did a public health intervention here, and we did another one here. So we see that there's an increase of people going to find the doctor there and up here too. So it worked. So those are some examples of some of the quasi-experimental types of designs in practice, and also doing research to provide the evidence for good public health practice. So I'm not going to go into a lot of detail. I mentioned that we did a health screening. This is a paper that reported out some of the results. One of the things that was a little bit counterintuitive was that we had people who were sick and they didn't realize it. And once they went through the health screenings, we saw that their spirometry was abnormal. They were ill and they didn't realize it. And there's a long answer to that I'm not going to get into right now, but that was a big finding. We also looked at the mental health side of things. Again, chlorine was the first chemical weapon used in warfare, so it's really good at freaking people out and putting fear of the enemy in you. That's why it was used that way. So people were seeing their clothes bleach white in front of their eyes. That's not a very pleasant thing to go through, not to mention coughing and drowning in your own fluid in your own lungs. So it was a traumatic experience. So we saw traumatic health in the mental health side of things as well, with panic and with PTSD as well. And we've looked at this further moving forward. We looked at the mill workers specifically, a lot of them, because they were there. Some of them were working in the mill at the time when this happened, and others weren't. And so but they also had really good baseline data because they were exposed to things on the job. And so we wanted to look to see if we saw changes in their occupational health records that they were having collected. And long story short, yes, we did. And so this is their lung function. This was before this happened. You can see this nice thing change back and forth. And then this happened, and it starts going down. This is FEV1, ratio. It's a measure of obstruction, lung function obstruction. And then the mill shut down because they kept having everything break because it just got corroded from the chlorine. So, and then we followed up with that in a study on our own, a cohort study. I'm just going to show you these pictures because I showed you another slide. In the post-recovery period, you have to keep asking questions. You have to keep doing the research. In this case, we went back to the community and said, what else do we need to do? And some of them, you give them a questionnaire and they climb up and they don't want to write it out. You give them a camera and say, tell me your story. How is your health different today than it was before? And then they light up and they go take pictures all over the place. And this is what we use. It's called Photo Voice, and one of my health education colleagues really led this team to do this. And these are some of the quotes that we got from those types of studies. Then you pull those all in and you get themes as to what are the main themes, and then you try to do the studies to address those main things that the community is concerned about. So really quick, I'm just going to zip through this. Our longitudinal cohort study, we saw that there was increased resistance within the people who were exposed in their airways. That's not good. It's a measure of lung obstruction. And so that's some of the work that we've done now, moving it into a cohort study. So this is a more traditional type of study design, long-term, kind of like what I showed you in Chernobyl. And these are all different types of outcomes that are related to potential emphysema-like effects and long-term health effects that really need to be assessed. So I'm going to blast through this and just show you a couple real quick slides to show you it's not just our cohort. This was a cohort of mill workers that we had pre and post data on. We didn't have the rest of the population, and only a small percentage of the folks who were really severely ill were mill workers. So we looked back to the hospital data, and we saw that there was an increase in hospitalizations for lung diseases. So again, just like I showed you before, they were actually getting better in their rates of hospitalizations for lung disease before, and then it reversed afterwards, and it stayed high for several years. We saw something similar. This is really strange, but this is for hypertension. The acute myocardial infarction and coronary heart disease were pretty flat, but we saw an increase in hypertension, which we think is a disaster effect, not necessarily, or it could be an effect of having COPD impacting the heart. Maybe we should talk about that. Anyway, we had a large team to help, because there's no way I could do any of this by myself. Not a single bit of it. So with that, I'll just say thank you, and thank our funders of this, at least the chlorine part of the funders, and ask for any questions. So I went through that really quickly, so I hope that was helpful. Thank you. Any questions? Yes.
Yeah, Eric, really nice. One of the problems it seems like with disasters is everyone is different.
Yes.
Maybe you can put it as a classification, but how do you address that? Like looking for those unknowns. What are the mixtures we're going to encounter?
Yes. Well, there are also parts that are the same. And so within the NIH and the CDC, they've tried to leverage that part of the equation and say, we understand that every disaster is going to be a little bit different. And you're going to need to go from doing nothing with a disaster to having to do a sprint in like 2 hours. And so how can we help you get there? They developed these resources where at least the common parts of the equation are available to have you start. So you're not starting from sitting still, you're starting from a running start. And then you can take those tools and finesse them to the individual type of disaster that you're dealing with, whether it be an airborne exposure, a water situation like Flint, or who knows what it might be. So it's a problem, but that's, as far as where we are in the science right now, that's about all we can do. I don't know if I answered your question.
That's kind of general in terms of the question.
Yes.
How do you feel that these method and this prior research has impacted our response and the efficacy of our response in Puerto Rico?
Puerto Rico, one thing I didn't tell you, but for those who are in the disaster world will tell you, everyone in disaster world will tell you every disaster is local. So, and that's part of the problem because, especially if you're on an island, the local people have to deal with the first 24 to 48 to 72 hours because before you get any federal assistance, you have to ask. So that's the disaster declaration, okay? Just because we've had a really bad history of federal troops moving into people's states and doing things, they've developed this situation where we won't come in unless you ask us to. And until that point in time, you're on your own. And it's a little bit difficult with Puerto Rico because it's a territory, it's not a state, they don't have the same kind of state resources. And so there was a gap there. So I would say, quick answer to your question, having not just Puerto Rico, but the Virgin Islands were smacked pretty silly. So, and their territories, they don't have the same kind of infrastructure that a state would have. That those tests of the disaster system were failures. And we have to go back and relook at this and finesse that a little bit for those types of situations.
You know, after Hurricane Katrina, that was part of the problem that the governor of Louisiana didn't realize that process.
Yes,
that
she didn't
had to
ask for any help. She just sat there waiting for help to come, and the feds were just waiting to go, but they weren't asked. So that was part of the problem. Yes.
So I think most of the things that you showed when you're looking at the effects of chlorine exposure in populations after the Graniteville incident, you're classifying people just based on as exposed because they were in the town. It's either plus or minus.
Plus or minus in the plume or not in the plume.
Okay. You showed a model where you were mapping out different
Yes.
levels. So do you
So
have
we
plans
have-
to go back and then try to
Yes.
develop some more detail? And
We have individual dose. We have area under the curve kind of thing. What we did was we estimated individual exposure at that location for that individual every 10 seconds based on that plume model and exported that into a separate data set. And from that we can get a nice exposure curve. That's an estimate. So it's the best estimate that we have. That model, we validated the model with animal toxicology data, and I didn't show it here in this presentation, but I could show you, I have the data to show that we have a lot of dead animals, dead plants, and that can kind of tell you where the plume was. And so we use that to calibrate our plume dispersion model. So we can get estimates of the peak exposure that they have in concentrations per cubic meter of air or per second. But we just don't have the sample size to be able to look at the dose response at that level because there's still a lot of uncertainty because those are estimates. They're not actual doses that are administered to the people. So there's a lot of variability in that. And these models, these are the best available to us, period, for researchers. They have better models in the military, but I don't have access to those. And I don't think there's a plan to be able to release those to the academic community unless they have secret clearance. But we don't, so this is something that's the best we can do right now.
but have you, like in the mill workers, you know where most of them were, right?
Yes.
So have you tried to use the exposure estimates
Yes.
and do associations?
That's what
with
the Eagles
changes
were,
in lung
and
function?
I'm sorry I went through that very quickly. The acute exposure guideline levels. So we know, crudely, we know that they were exposed within an Eagle 1, 2, or 3, which is basically a mild, moderate, or severe exposure. And so we can contrast those, and we do have a paper that we're hoping to submit soon that does look at that dose response, and at least in looking at the highest exposed Eagle group to the rest of the group.
Right.
Yes.
Kind of like a two-part question. So I was in the military, so I was part of that response, like to Fukushima. So so there's the question will come into kind of a practical portion. How do you navigate kind of the civilian, bureaucratic, political response to disasters. Because in the military, it's very easy. You know what it is, and there's not much of a question. There's one guy who says, "This is what we're doing."
That's the incident
This is what we're
command
doing.
structure of communicating back and forth. And so all those acronyms that I showed in that one slide, the National Incident Management System and Incident Command System, you set up, and I kind of showed up in there a little bit. You have ESFs, or which we call emergency support functions, and health and medical is one of those. And so you have ESFs, and then everyone gets together in the Emergency Operations Center. And so that's a longer discussion,
Right.
but it's managed by the public safety folks. So, and hopefully folks are familiar with that type of system before something like that happens, so everyone knows who's going to go into the Emergency Operations Center and how long they're going to be there and what they have to do when they get there. So that's all part of the process that came out in the 90s and early 2000s to really help finesse that. So I don't think that part of the equation is going to change that much. And if you have really good protocols and plans, like you said, the military knows what to do. If you have really good disaster preparedness plans within your public health agency, you're going to know what to do.
So in the case of Graniteville, why did they not categorize that
As a major national
Right.
disaster,
Yeah, that's what I was getting to. That's what I was getting to that question because
Okay.
I didn't understand why that case would have been considered.
we've never figured that answer out.
Okay.
And we've heard a dozen different potential answers to that. So the short answer is we don't know. Probably just politics. The most likely answer is that they figured that they didn't need to make it a national disaster because there was a single responsible party that caused it. It was the railroad. And so they figured, oh, it's not our job, it's the railroad's job. Let them fix it. Well, that's not going to work that well. So they just got 700 lawsuits. How are they going to manage that? So they did. Questions? Sorry, I went over time a little bit.
Okay, thank you very much.